Hello, good evening. Nice to see you again. Tonight I'm sitting interestingly in a hotel at the Radisson a collection in Moscow because tomorrow we have an aligner meeting here, and it's a great pleasure, of course, to lecture at this meeting. In the last three webinars, we've been talking about how we can use mini implants, especially in the palate, for distalization, for mesialization, also for early class 3 treatment. And you saw that it's very recommendable and I think very smart to combine the sliders with aligners. So this is the reason why I'm here in Russia and lecturing at the aligner meeting tomorrow, because of I think this combination of sliders and aligners is the future for orthodontic treatment. And you saw that we are doing the bodily movements, especially in the upper arch, with the Bene slider, with the mesial slider, and with the easy things afterwards with aligners. And I think this is a very smart combination. So again, welcome to this webinar. This is the last webinar. And today I'd like to speak about pre-prosthodontics, how we can work together with our referring dentists, with our referring implantologists, how we can help our dentists with their patients. And I will speak about molar uprighting, molar intrusion. And I think since I'm doing many of those pre-prosthodontic things, more and more dentists are referring to our university for this for these treatments for these patients, and so maybe it's also good marketing for you as orthodontists to get more referring dentists. So interdisciplinary cooperation, this is the main topic for today. So today I don't speak so much about distalization, mesialization, etc. I will speak about those patients where we have to work together with our dentists, referring dentists, general dentists. Molar uprighting, molar intrusion, as mentioned, two main topics. But I like to speak also about forced eruption of impacted teeth, especially in those patients that are primarily treated by dentists. And the question is how we as orthodontists can help them. I like to speak about bone generation and soft tissue generation using distraction technique. And this is especially helpful in patients who have ankylosed teeth. And last but not least, I like to discuss with you if maybe mini implants can help us to preserve bone, especially in those patients where we have missing teeth in young children, missing lateral incisors. And two webinars, or in the second webinar, I spoke about mesial slider and how to close the space. But of course, we still have patients where we are opening the space for future dental implants. But for those patients who are getting their implants, if they are 20, 22, maybe 25, we need something in between in the meantime, and we will speak about the so-called children's mini implants. So interdisciplinary cooperation, this is the topic for today, and I hope you will like my ideas how we can improve the cooperation with our referring dentist. So let's start first with molar uprighting and molar intrusion. And this is typically what we see, or what dentists see in many patients, if there is a missing lower first molar. The second molar is tipping forward and the upper molar is extruding. So again, this is a very typical situation, and this happens, I think, once a week in every dentist's office. And then the dentist or implantologist wants to insert a dental implant and the lower arch, or even a bridge from 5 to 7. So most of the dentists, unfortunately, are cutting, are grinding the over-erupted tooth. And if you do a lot of grinding and cutting, of course, you need an endodontic treatment. So maybe this is not the best solution. Some dentists are even extracting the over-erupted tooth, and of course, this is, I think, a very poor treatment for our patients. For the implantologist, this may be good because then he can insert 2 implants. But if you are the patient, I think you will not like it. Okay, so I like to speak about mechanics, how we can intrude the over erupted molar. So this is, from my point of view, probably in most of the patients the best treatment option to intrude the over erupted molar, but it sounds easy. It's not so easy, to be honest. But I like to discuss with you different strategies how to intrude this molar. In the lower arch, it seems recommendable to upright the molar, not to grind or cut it, not to extract it, and I will speak about molar uprighting mechanics as well. So in the past, we needed many brackets just for anchorage. Okay, so for molar uprighting and molar intrusion, we have bonded many brackets, and of course, this is not very much loved by our patients, since most of the patients, they don't want a visible orthodontic treatment. They like to have an invisible treatment with not so much brackets and wires in place. So this is what I like to speak about today. Mechanics for molar intrusion and molar uprighting. And as you can see, mechanics can be much smaller, much smarter if we don't have to put brackets on many teeth just for anchorage. If we use mini implants for anchorage purposes, the design can be, from my point of view, much more interesting. So let's start with molar uprighting. And if it comes to molar uprighting, we have, from my point of view, more or less 3 different mechanics. And on the left side, number 1, I think this is the easiest mechanics. So I will jump into my pointer. So question you have to ask yourself first: is there space distally of the molar? So this is, for instance, the second molar, number 7, and you want to upright it. If there is space here for a mini implant, what means space? Space means, is there attached gingiva? This is very important. This is what we learned in the last 20 years in our university. It is not recommendable to insert mini implants in thick, movable mucosa. It's always recommendable to insert mini implants in thin and attached gingiva. So the question is, there attached and thin gingiva distally from the molar. Okay, so right here, okay, do we have in this area thin and attached gingiva? Then mechanics number one is the easiest mechanics from my perspective. And I like to show you one case. And again, this is from my point of view, the easiest mechanics. So this is a patient of mine, and she was referred from a dentist to my office for uprighting of the mesially tipped molars in the lower arch. I think these are first or second molars. I don't know for sure, to be honest. So again, easiest mechanics. As mentioned, if there is space distally from the molar you want to upright, and this space should be with thin and attached gingiva. Okay, so mini implants posterior are leading to the easiest mechanics. Just attach a elastic chain from buccally to the mini implant to the lingual attachment. So very easy mechanics. You will get an uprighting force and additionally a little bit intrusive force, and this is always helpful. Why? We must avoid primary contact. Okay, this is the rule of thumb and very important. If you want to upright molars, primary occlusal contact of those teeth you want to upright must be totally avoided. I have many patients where I successfully uprighted molars and I had problems, failures, mostly in those patients where I couldn't avoid the primary occlusal contact of the molar that was to be uprighted. So have a look on this. Yeah, how can we avoid the primary contact? You can, of course, grind or cut the if there's an old filling or old crown, you can grind a little bit to avoid this primary contact, but please have an eye on this. This is crucial. Yeah. In this patient, I didn't cut the lower crown. I have cut the upper denture. Again, main goal is that you can upright these teeth and occlusal contacts should be avoided. Again, this is very important. This is the reason why I like to repeat this a couple of times. So easy movement for the tooth. It's an uncontrolled tipping. So uncontrolled tipping usually doesn't take much time. This mini implant in the second quadrant stayed very stable. In the fourth quadrant, this mini implant moved a little bit, but it was still stable. So sometimes mini implants move a little bit in the bone, but still can be stable. But it doesn't matter. If you are using direct anchorage, mini implant movement is not a big issue. Yeah. And in this case, you see we have uprighted the molar, even though the mini implant moved a little bit. So from here to there in around about 3 months, so very quick from my point of view. So it doesn't have to take 1 or 1.5 years. So after successful uprighting, we need, of course, some retention. So I personally, in this case, have removed the elastic chain and have inserted steel ligatures, as you can see here, just to avoid tipping of the molar into its old position. You see some perio problems right here. And this is, of course, also very important and crucial. Perio treatment should be done before the treatment, and oral hygiene must be perfect during these pre-prosthodontic treatments. In the meantime, the patient has received a bone augmentation from the implantologist. A couple of months later, received dental implants and the crowns on top of it. So this is the final outcome. Again, I still see a bone pocket here, and this must, of course, be cleaned by the patient properly. And there was some crowding in the lower arch, but this was not an issue for the patient and not an issue for the referring dentist as well. Goal was just uprighting of the lower molars. Patient was happy at the end. So again, this is the easiest mechanics. My recommendation, if there is space distally from the molar you want to upright, insert a mini implant, use an elastic chain. In most of the cases, there is not enough space posterior, distally from the molar you want to upright. So mechanics number 2 is use a mini implant or a dental implant that is mesially from the tooth you want to upright. So, of course, if there is a dental implant to be inserted later, this is the best anchorage unit. So ask your referring dentist, are you inserting a dental implant? My recommendation, use it. I'm doing this very frequently. Using dental implants, use some resin, and then you can put a bracket on top of the healing cap or something like that. So in this case, there was not a dental implant to be inserted. There was a bridge plan, so I used a mini implant. And this is my favorite uprighting mechanics. If there is no space distally, so you see distally there is thick and movable mucosa, so don't insert in these areas. My strong recommendation. Then we have to go mesially. We can use a benefit mini implant with a bracket on top, bracket abutment on top, and this bracket abutment can be fixed on top of the mini implants in 12 different positions. So you can first insert the mini implant, and then you can adjust and fix the bracket abutment on top. So this wire is a 16 by 22 TMA. This is my favorite uprighting wire, TMA, so better titanium. And if you make a bend here, and here, the crown cannot tip distally, then the root will be uprighted. Okay, so this is a trick we learned during our orthodontic treatment, orthodontic postgrad program. But of course, this takes longer. If sometimes we want to speed up the treatment, we spoke about the wrap phenomenon. Of course, then you can make 3 holes in this area. We call this micro osteoperforations because uprighting of roots usually takes a lot of time. Okay, so ask the patient if they want to speed up the treatment. You can make 3 holes, buccally, micro osteoperforations. This helps a little bit to speed up molar uprighting, because usually it takes some time. In this situation, it took, I think, around about 7 months from here to there. So it took quite a long time because I have made these 2 bendings, and the root can only move forward and the crown cannot move distally. Okay, again, next time, this was the patient was, I think, treated 12 years ago. So at that time we didn't know much about micro osteoperations. So nowadays I think I would offer at least to the patient this micro osteoperforation speed up. So this is after uprighting. There was still a little bit derotation. So I have added this elastic chain for final derotation. And this is the molar that is uprighted and derotated at the end of the treatment. Now I've sent the patient back to the referring dentist, and I've added a little bit resin right here. Why? I wanted to avoid overruption of the lower upper second bicuspid. Okay, another patient, another adult patient that was referred by a dentist, and the dentist asked for uprighting of the second molar and intrusion and buccal movement of the first molar. Again, our favorite mechanics and favorite wire is 16 by 22 TMA. And why not use one mini implant for 2 different purposes? In this case, for both uprighting of the second molar and intrusion and buccal movement of the first bicuspid. Okay, so this is a benefit mini implant. On top, you have this bracket abutment, and you can ligate in this 16 by 22 TMA arch wire. Dimension of the mini implant is 2 by 9 millimeters. Okay, so this is how it looks like in the radiograph during the treatment and at the end of the treatment. Okay, so molar is now uprighted, second molar. First bicuspid is intruded and moved buccally into a fine occlusion. The patient didn't care about the deep bite, etc. It was just the goal to help the dentist before inserting a dental implant in the area of the lower right first molar. Now the mini implant was removed. You need a retention for the time when the dental implant is healing. Usually this takes 3 months in the lower arch. And finally, a crown was inserted on top of the dental implant. So, mechanics number 3. If there is no space distally and no space mesially, we must go with our mini implants in between the roots. What I don't like too much, to be honest, but if there's no space distally and mesially, this is the only option. Okay, this was a patient of mine. She was already treated before orthodontically. Occlusion was nice, everything was okay, but in the 4th quadrant, the second molar has tipped severely. So she showed up in our office at the university and asked, what can we do? Option number one, we can take out the second molar, wait for the third molar. Option number two, take out the third molar and upright the second molar. So both is, I think, from my point of view, possible. And we have proposed both options to the parents and the patient. And they opted for extracting of the wisdom tooth and uprighting of the second molar. But again, there is no space distally, no space mesially. So we can either use teeth and put brackets on at least the teeth in the fourth quadrant and front teeth, but she was not happy with this because she already had orthodontic treatment. And so we offered her an alternative using mini implants in between the roots. And if we have a closer look, there's enough space in between 4 and 5 for mini implant. If we are inserting mini implants in between the roots, we're mostly using 1.5, 1.6 millimeters as a diameter. Okay, so you see there's a retainer in the lower arch, in the lower front teeth area. So again, she was already treated before, so she was not so happy to get brackets for the second time. Again, we had enough space in between 4 and 5, so we used a mini screw. It's called Quattro system from PSM. And the Quattro system has a nice head. It's the same head or a similar head like a bracket. And this is the reason why we can ligate in a wire. So right here, you see the Quattro head. Yeah, this is a conventional ligature. A conventional ligature that is used to fix wires to brackets, and this is an 18 stainless steel round wire. Okay, so this is the anterior part of the mechanics. This is an open spring, and this is a tube. And now it becomes interesting. There's an open spring again, and this open spring is pushing the wire distally. And as soon as this wire is pushed distally, you get a force distally here, and this is the reason now why the wire must be round. Okay, because it must rotate in the tube. So we have done this mechanics many times, and it works very well. We only have to have a look at the antagonist. If there is an antagonist, there is not enough space for the bracket, so this may be an issue. Okay, so have a look at this situation. So this is how the mechanics looks like, and from the occlusal point of view, and this is how the mechanics looks like in the radiograph. Again, in between 4 and 5, there was enough space for the mini implant. This is the open spring, and the wire rotates now in the tube. So we get a distal force. We get a distal force for uprighting. Okay, so this is after a couple of months. The molar is uprighted. Controls are every 6 to 8 weeks, and this is the situation after 7 months of treatment. And you see, it worked out very nicely without any major problems. Next step was now I used a new wire for space closure, used the same mini implant. So this is an elastic chain, 18 round wire for mesialization. There was a space of around about 1.5 millimeters. This is after space closure. So space closure took another 2 months. This is after end of the treatment, after removal of the mini implant. And patient was very happy that we have fixed her problem with not many brackets in place. Another patient where we did uprighting of the third molars in this case. Please have a closer look at the radiograph. You see the third molars are tipped. This happens from time to time. Usually we would think about extraction of these molars. However, he had severe caries in the area of the lower sevens. Sorry. And a deep filling in the third quadrant as well. So, as you can see, retainer is in place. So he was already treated before. So treatment plan was in this case extraction of both lower second molars and uprighting of the third molars. Okay, so this is after extraction of the second molars. This is the idea for the mechanics. The treatment goal was uprighting and space closure to the mesial. And to avoid many brackets, he was not the best cleaner of his teeth, so oral hygiene was quite poor. It's another reason why we maybe should avoid a second orthodontic treatment with full braces. So this is the uprighting spring. Sorry, I will remove what I have done here. So this is how the uprighting spring looks like. It's again a 16 by 22 TMA arch wire, and treatment goal was uprighting and mesialization. And to avoid movement of the first molar, it was now coupled with one mini implant. We call this indirect anchorage. Okay, so I personally prefer direct anchorage in most of the cases. However, in some situations, indirect anchorage still makes sense. So again, this is how it looks like. We use the tube, double tube molar band. This is a mini implant coupled with resin. We talked about this, I think, in the first webinar. The mini implant is inserted with a strong angulation. Okay, so don't insert it like this. We have to insert it like this. Okay, that you have enough space between the roots and enough bone, of course. But buccally, we want to stay in the fixed mucosa. This is the uprighting spring, 16 by 22 TMA on both sides. This is during the uprighting process. And now it comes to the next step, space closure to the mesial. As you see, oral hygiene is poor, so especially in those patients, it's recommendable to avoid many brackets on the teeth. This is at the end of the treatment. Molars are uprighted and spaces are close to the mesial. And this is after debonding in this situation. So this was it about molar uprighting. You saw a couple of different mechanics. Now I like to speak about molar intrusion, how we can intrude molars if they are over-erupted. Second indication for molar intrusion mechanics are open bite cases, but this is not the topic of the webinar today. So I just like to show you one case where we have intruded molars to correct an open bite. So down here you see different mechanics, how we can use mini implants for molar intrusion. And this is how we started. We used to insert mini implants in between the roots. Okay, but then you might have the problem that you have a higher failure rate and you have sometimes not enough space between the roots. Another area where we can insert mini implants is in the infrazygomatic crest. And certainly we can use mini implants in the anterior palate, what is from my point of view the best area. So let's start with mini implants that are inserted in between the roots. Okay, this is one of the papers where this has been published in 2007. You always need a force application buccally and lingually. Okay, sometimes there's not enough space. This is the problem why I personally don't like mini implants in between the roots so much. Okay, if there is not enough space in between two roots, you can go to a different spot and use a cantilever mechanics, as you can see, for instance, right here. So I like to start with one of our first patients treated around about 20 years ago. Typical scenario, lower first molar is missing and the upper first molar is over-erupted. Lower second molar is tipped. So treatment goal, intrusion of the first upper molar and uprighting of the lower second molar. Okay, so very typical situation. But please have a look. Sometimes there's no space between the roots, and even me, I'm afraid to damage the root. So what can we do? Nowadays, I would go from the very first minute to the anterior palate and design the mechanics only with mini implants in the anterior palate. But again, this was treated 20 years ago. So we changed the insertion site for the mini implants a little bit. We saw, okay, we have space here a little bit and we have space here. So the idea was a cantilever mechanics, as you can see right here. So this is a lever arm for mini implants in between 5 and 6 and 4 and 5. And this arm is attached now to the molars. Usually this arm is like this. So an intrusive force is applied buccally, but again, you always need also a palatal force. So palatal force is from a mini implant in the suture area. So this is after 6 months of treatment. You see a nice intrusion of the first molar in the lower arch. The second molar was uprighted. You have seen the mechanics we are usually employing for this purpose. Again, before and after in this patient. After removal of the intrusion mechanics, retention. But again, we moved to the palate and we don't use mini screws in between the roots so much anymore. We are afraid to damage a root, and the major reason is a much higher failure rate. Okay, in the anterior palate, the survival rate is much higher. Maybe at the beginning, if you start in the anterior palate, you will see some more failures. But as soon as you are familiar with the best insertion sites and the perfect insertion procedure, you will have a very, very high success rate. So where to insert? We talked about this in the last 3 webinars. We are inserting in the T-zone. This T-zone is very easy to identify. We primarily just have a look for the rugae, and we stay posterior from the rugae. Okay, so 1, 2, 3 rugae. 1, 2, 3 rugae. This is what we find, and we stay posterior. So you don't need a cephalogram, you don't need a cone beam CT to find this good position. Only you look for the rugae. This is a rule of thumb. And anteriorly in the area of the bicuspids, you can insert either median or paramedian. In the area of the molars, you must stay in the middle because paramedian, the bone is paper thin. It doesn't make sense to insert them posterior paramedian. Okay, so we more or less again have this T-zone if you are in the area of the bicuspids. It's many times in between 5 and 6. This is the best insertion site. But don't look so much for the T's. Look more for the rugae, for the soft tissue in the anterior palate. So, so I like to show you the design of the mechanics if we are using mini implants in the best insertion site, which is the anterior palate. We call this appliance mousetrap. So this was a patient with an over-erupted first molar in the first quadrant because of missing molars in the fourth quadrant, and this happens very frequently. And again, my recommendation, go to your referring dentist and tell them that you can do these things and like to help him with these patients, and they will love you. Okay, so this is my strong recommendation for you. So this was a sketch from the dentist. Again, we call this appliance mousetrap because it looks a little like a mousetrap, especially if you have intrusion springs on both sides. Many patients, we only have intrusion springs on one side, but if you have intrusion springs on both sides, it looks like a mousetrap. This is the reason why we called it mousetrap. Okay, so this was the first paper about it, and I like to show you the design of the mousetrap. We have a TPA in place. Very easy. Everybody knows a TPA. This the TPA has the goal to avoid tipping of the molar. And after inserting a TPA, we are using 2 mini implants and a flexible arch wire with a bend plate. And now you can bend this bend plate wire, attach it to the molars. As a result, you have an intrusive force. If you want to, you can measure this intrusive force. Should be around about 100 gram for every molar you want to intrude, more or less. We should be in the center of resistance, so the line of force should be in the center of resistance. Otherwise, you may see distal or mesial tipping of the molar. The good thing, once you have activated it, you don't have to care much. Yeah, so you have a very good control of the force. You have a very good control of the amount of the force. So these are the two advantages. Disadvantage of this mechanics, of course, you have a wire in the palate, and adult patients have to adapt to these wires for a couple of days. So everything in life has pros and cons. Okay, so this is how it looks like. We are using this bender plate with a flexible arch wire. This is the situation 7 months after insertion of the mouse trap. In the first 2-3 months you don't see much, so we have to be patient. Yeah, a lot of bone has to be removed, remodeled, so take your time. But it's a very predictable appliance. Once you have activated it, just check it every 6 to 8 weeks. Very relaxed, very predictable. Okay. You can apply forces on the first molar. Of course, if you have an over-erupted second molar, you can also use the mouse trap. This is the design, how it looks like. Again, it's the same story. We have a TPA in place and intrusion arch wire from the 0.8 bender plate. Yeah. This is after a couple of months. You see the nice intrusion of the second molar. Usually takes round about maybe 6 months for round about 2 to 3 millimeters. Another patient where we have 2 missing second molars in the lower arch, and the upper arch, the second molars were over erupted. Interestingly, there's still a wisdom tooth in place. This should be extracted later. So primary goal was intrusion of the over-erupted upper second molars. So this is a mouse trap in place. Always looks the same. This is after intrusion. Patient asked for aesthetic treatment and aesthetic correction of the front teeth as well. So we have combined aligner treatment anteriorly with molar intrusion posteriorly, because molar intrusion is not so easy. So with aligners only, this may be a problem. This is a patient after treatment, after intrusion of the second molars, still in aligner treatment, at the end of the aligner treatment. Yeah. You have to take care of retention, of course, otherwise the molars are going to over-erupt again. Very important. Yeah. Another patient, adult patient, over-erupted first molar in the second quadrant. And she asked for aligner treatment as well. So mousetrap appliance in place. After 6 months of treatment, you see the amount of the intrusion. It looks always very similar. And in this case, we did not aligners and the mousetrap simultaneously, but after each other. So in step number 2, a scan was made for Invisalign treatment. And this is a patient after Invisalign correction. Now I'd like to show you a funny case. Why is this a funny case? Because there was a little bit of misunderstanding in the communication. And after successful intrusion, she didn't come for a couple of months. And then you will see what happened. So, but this was the situation at the beginning. Yeah. The referring dentist has inserted a dental implant here, but then, oops, he saw there's no space for a crown. Okay. He has sent the patient to me for intrusion of the second molar. So treatment goal was like this: intrusion to get enough space for the crown in the third quadrant. This is a mousetrap in place. After successful intrusion, you see molar has been intruded around about 2.5 millimeters. So I said to the patient, please go to your dentist. I think you are finished, and the crown can now be fabricated in the third quadrant. But I don't know why. She misunderstood something and she didn't come back in the next couple of months. And so this was a situation where I sent her back to her dentist. But again, she didn't come to me for, I think, 3 more months, and this is what happened. So very impressive from my point of view. You see how effective this mechanics works. Of course, this is an over intrusion of an over erupted molar, but it works very nicely. So I didn't see her for, I think, 3 or 4 months, and we saw another over intrusion of around 3 millimeters. Okay, so not a big problem. As soon as you remove the force, the molar is going to drop down to the perfect position again. But now, of course, there was enough space for the lower crown on the dental implant. Yeah, you see, over intrusion, funny story, yeah, over intrusion of the over erupted molar. Yeah. So again, if you remove now the appliance, the molar is going to drop down again, and at the end it will be a nice occlusion. So another patient with over erupted second molars, and now we wanted to try something new. You saw the mousetrap. The mousetrap had always a TPA wire in place to avoid tipping. But of course, adult patients, they don't want so much wires in place. So we tried something new. We tried to use the mini mousetrap, and the mini mousetrap is an appliance without this TPA wire. Okay, so it's just this banner plate with a flexible arch wire. Advantage of this mini mousetrap: there is not so much, not there are not so many wires in place. You can avoid the need for TPA. Disadvantage, we have to look properly if this is good activated. Okay, so there's a risk that the molars are tipping buccally, lingually, or distally if you don't have activated this wire properly. So everything in life has pros and cons. This is the advantage and the disadvantage of this mini mousetrap. But luckily, in most of the situations, this works very properly. This is after molar intrusion. Another patient where we used this mini mousetrap. We have an over-erupted second molar in the upper arch, missing molar in the lower arch, and the referring dentist asked for intrusion of this molar. This is a mini mousetrap in place. 6 months later, you see before and after a nice intrusion of the second molar. So it works nicely, but we have to activate it properly. So I promised you one case with the mousetrap used for an open bite correction. Usually, again, this is not my topic today, but we can use the mousetrap not just for intrusion of over-erupted molars, but also for molar intrusion in open bite cases. Okay, so this is a patient I like to show you. Open bite case, mousetrap in place. Of course, we need brackets or aligners on the other teeth as well. This is before the treatment and follow-ups after 12 months of treatment. You see a nice closure of the open bite. By the way, oral hygiene is not so good if the patient does not clean the mini implants. Sometimes it looks a little bit like there is a small inflammation. So please instruct the patients to clean the mini implants with their toothbrush every day. Use chlorhexidine jelly. And this is how it looks like if the patient does not clean the mini implants. Okay, and then you have the risk that there's a failure. So my recommendation, clean them, instruct them, use chlorhexidine jelly. Yeah. So in this case, they survived somehow the mini implants, but we have also cases where we had a failure because of poor oral hygiene. So this is 1 year and 2 years in retention. So of course we have to take care of the tongue position, very important. If you close an open bite, you have to check the reasons for the open bite, very important. So what else happened? Very interestingly, if you are successful with your molar intrusion, you will always see auto-rotation of the mandible. So in this case, you see you have changed the face from a class 2 to a class 3 because of this auto-rotation. Of course, you have additionally chin growth, but I think it's a quite impressive change of the look, of the profile look of this patient. This is because of molar intrusion and auto-rotation. So what did we learn from those patients? We learned that molar intrusion is maybe a good option to correct an open bite in class 2 patients, but it may be risky in class 3 patients because at the end the class 3 becomes more severe. So please check this before you think about molar intrusion. So this was it for molar uprighting and molar intrusion. Next topic will be forced eruption of impacted teeth. Yeah? How can maybe mini implants help us to avoid dental side effects on adjacent teeth? Yeah? Typically, we as orthodontists have impactions of upper canines, and if you want to align an impacted canine, we have to apply force, and if we use adjacent teeth, you have the risk that they are going to be intruded. If we are using the molars as anchorage, you have the risk that they are going to tip. Okay, and I like to speak about possible mechanics to avoid intrusion of adjacent teeth and tipping of molar teeth. Okay, so we always have reactive forces and moments on anchorage teeth. This is how it may look like. Yeah, tipping of a molar, intrusion of adjacent teeth, and especially this may become a major problem if the tooth is ankylosed. Okay, but even if it's not ankylosed, you see sometimes severe side effects. Why? Using a lever arm from the molar, yeah, you will get your extrusive force on the canine, but you get additional tipping of the molar. So of course it would be nicer if this molar tipping can be avoided. So please have a look right here, a case we try to align and the canine, use the molar, yeah, the molar tipped severely, and this happens quite frequently if you don't have a good anchorage in place. This molar was even connected with the contralateral molar, so some colleagues say, okay, use the TPA to avoid this tipping, but please have a look, even the contralateral molar tipped, because these tipping moments are quite high if you want to align canines. And I like to speak now about the possibilities or possible mechanics, how we may avoid these side effects on anchorage teeth. This is, of course, worst case scenario. Patient referred to my office. Somebody like an orthodontist wanted to align the canine, but everything moved, but not the canine. The reason why? The canine was ankylosed. Of course, patients are very unhappy. High risk of root resorption if you intrude adjacent teeth in such severity. Another patient of mine, yeah, she was treated before at another orthodontist office. This orthodontist wanted to align the canine in the second quadrant. Everything moved, but not the canine, because it was ankylosed. So this is typically what happens if a tooth is ankylosed. The adjacent teeth are intruded. The orthodontist saw this problem and he wanted to correct this intrusion. He used lower teeth as anchors, but it made it even worse. So the teeth in the third quadrant extruded, and at the end, the whole occlusal plane was tilted. So very dramatic situation. Okay, so again, it would be maybe better to avoid dental teeth as anchors. Of course, if you have an easy situation, you don't need mini implant in every situation. Yeah, but if you have a severe impacted and displaced tooth you want to align, I think it's strongly recommendable not to use teeth as anchors, because the anchor teeth might move in directions you don't want to. Okay, so again, this was a patient very unhappy with the situation, and it was very difficult to get out of this situation. Later we'll speak about how we can align impacted teeth using PDL, periodontal distraction. But first, I like to speak about possible mechanics, how we can align impacted teeth without using adjacent teeth as anchors. This was published in 2012. We talked about this, the difference between direct and indirect anchorage in the last 3 webinars. There's always the possibility in each and every anchorage situation we can go for direct anchorage or indirect anchorage. Again, what means direct anchorage? Direct anchorage means the force is applied only on the mini implant. Indirect anchorage means the force is applied to an anchorage unit that consists of teeth and a mini implant or a mini plate or a dental implant. Okay, so we can choose either direct anchorage or indirect anchorage. I'm a big fan of direct anchorage, Bene slider, mesial slider. All these mechanics are direct anchorage mechanics. However, if it comes to alignment of impacted teeth, especially in young patients, we are choosing in many cases indirect anchorage. Why? This is a little bit more stable, because if you have one mini implant like on the left side here, and there's a flexible arch wire, there's a risk that the patient is jiggling with the fingers, with the tongue. So we see sometimes failure of the mini implant. Okay, so especially in young patients, we are choosing indirect anchorage if it comes to alignment of impacted teeth. Okay, this is what we learned in the last 20 years. So let's have a look at some patients where we use direct anchorage. The topic of today's webinar is interdisciplinary treatment. So I like to show you especially cases where we have aligned teeth in adults. So first patient, he was sent to my office from the referring dentist, and there was a wisdom tooth in place. And the dentist asked me, Dr. Wilmes, do you see a chance to align the impacted wisdom tooth? The reason is this first molar was to be extracted. There was a severe periodontitis, so we had to this first molar was to be extracted. Okay, and the dentist asked me, can you please align the impacted wisdom tooth? So this was the mechanics. the wisdom tooth was surgically exposed. 2 mini implants were inserted, and this is a bender plate with an 0.8 wire in place. One side is cut off, and this is the mechanics. Again, there was an extrusive force now applied to align the impacted wisdom tooth. Of course, you can try to align it, but we have to be honest, of course. The older the patient is, the higher the risk will be that the wisdom tooth does not move, okay? So the older the patient is, the higher the risk of ankylosis will be. But this wisdom tooth moved, luckily. So this is a situation after extrusion of the wisdom tooth. Again, the first molar was to be extracted due to severe periodontitis. After removal of the appliance, and now there is a bridge in place from the second bicuspid to the wisdom tooth. Okay, so why not? From my point of view, a smart idea from the referring dentist to align the wisdom tooth. Another patient with a nice interdisciplinary treatment. We have a female patient, and in this patient, the root has fractured, or the crown has fractured very deeply. And the dentist asked me, is it possible to extrude the root maybe 1.5 millimeters? Why? To facilitate prosthodontic restoration of this root. Okay. There are some colleagues using adjacent teeth for extrusion of roots. Of course, you can do that, but there's always a risk that the adjacent teeth are moving. So in the upper arch, you can use mini implants in the anterior palate for forced eruption of this impacted or deeply fractured root. So I asked the dentist, can you please make a post in the root with a small hook like this, since I need something where I can attach my force. This is a mini implant in place, bracket abutment in place, 16 by 22 TMA arch wire, as we have seen before. This is after extrusion of this deeply fractured root. You see round about maybe 2.5 millimeters of extrusion. Now, of course, we need some retention. This retainer was bonded for around about 3 months to keep the extruded root in place. After 4 months, you see a nice bone regeneration. And now the dentist made a new crown in the area of the lateral right incisor. This is the final outcome. Patient was happy because we have avoided a dental implant, what is in many situations a aesthetic problem, especially in long term. Dental implant in the aesthetic area may look good after insertion, but we never know what happens in 10, 20, 30 years. Okay, so maybe our own teeth are still better compared to dental implants. So, a young patient with an impacted second molar, and referring dentist asked me, she doesn't want to be treated orthodontically. Can you align the second molar. Again, we use the bender plate with 0.8 millimeter 0.8 millimeter arch wire. This is after a couple of months. Line of force is distally and activated for extrusion. After removal of this appliance, I left the mini screws because she went to the States for 1 year. She will come back for maybe a second treatment with distalization. Okay, 2 more topics left. Bone generation using PDL distraction. What can we do with ankylosed teeth? We spoke about the problem that everything is moving if we have an ankylosed tooth, but not the ankylosed tooth. So what is the chance for this ankylosed tooth? Do we have to extract it? Some orthodontists are loosening the tooth and applying a conventional force. However, then you have the high risk of re-ankylosis. You still have a risk that the anchorage teeth are moving. If you extract this ankylosed tooth, you have a big defect of soft and hard tissues, and this may be an issue for the prosthodontic rehabilitation using dental implants. You can go for an osseous distraction. What does it mean? We are cutting the bone and fixing a distractor in this area. It's very invasive. You have the risk of root damage of the adjacent teeth. So I like to speak about the fourth alternative, and this is PDL distraction. So it's not a distraction of the bone, it's a distraction of the periodontal structures. So what does it mean? We are stretching the periodontal structures, but before we have to loosen the tooth. So the idea is we are loosening the ankylosed tooth, wait for 1 week, and then we are stretching the fibers. We are pulling the ankylosed teeth out of their socket. Okay, this is a paper where we have first described this method. By the way, all the papers I have mentioned are available for free on our university website. So at the end I will show you this website. You can download them all for free. Okay, so this is a protocol. The ankylosed tooth is loosened and very much as almost as much as you are going to extract it. Okay, so this is very crucial. The tooth must be very loose, so almost like you take it out of the socket. Then we wait for 1 week. This is similar to osseous distraction, which was invented in Russia. Everybody knows Ilazov, who has invented this. And then you pull the tooth with a speed of 0.5 millimeters each day out of its socket. Yeah, this is similar to osseous distraction, but again, we are not cutting the bone. We are stretching the fibers. We are pulling the tooth out of its socket. It's a last chance for ankylosed tooth. What is the goal? Of course, we want to use the ankylosed tooth, but primary goals are we are generating bone and we are generating soft tissue. So in total, we have 3 goals. We want to use the tooth. We want to generate soft and hard tissue, because even in those cases where the tooth cannot be used over the next decades, you have at least generated a hard and soft tissue. Okay, so I'd like to show you now a case where we used mini implants for anchorage. If you have a look at the article I have mentioned, you will see we have started with dental born distractors, but of course, in most of the cases, the adjacent teeth are already very much intruded. So it's not nice to intrude them even more using this distractor. So smarter is to use mini implants and a mini implant born PDL distractor. Okay, so for this purpose, we are using 3 or 4 mini implants because the forces are very high. Again, mini implants were inserted, take an impression for the design of the distractor with impression caps and laboratory analogs. We talked about this in the last webinars. This is the design of the distractor. We have a rigid wire. We have a screw that is activated daily. This screw is the same screw we are using in a Schwartz plate, in an active plate, so in removable appliances. And this is a distractor in place. It's not so super comfortable for the patient, to be honest, but this distractor is in place only for a short period, only for 3 to 4 weeks. So this is tolerable for the patient. Okay, so distractor is in place, and now the patient is activating this screw every day. Okay, of course, you must teach them how to activate this screw. This is after 1 week, after 2 weeks. You see the tooth is pulled out of its socket. Yeah? To be honest, all of those teeth have a small defect. And this defect was, of course, the reason why the tooth was ankylosed. Okay, so we have so far distracted around about 30 teeth, not 13, but 30. Most of these teeth are still used, but we had to extract some of them because of this defect. That was the reason for the ankylosis. This is after 4 weeks, so usually it takes 3 to 4 weeks. Again, you are pulling the tooth with a high speed out of its socket. Yeah? The good thing, since you do it not in just 1 day, you can generate bone and soft tissue. So long term, for those teeth, it looks okay, but in all of them you see a small defect, and mostly this is in the area of the enamel cementum junction. This is very typical. And this is the reason, probably was the reason for the ankylosis. Okay, so you see this small defect, yeah, right here, yeah. But even if this tooth has to be extracted in maybe 5 or 10 years, you have generated bone, you have generated soft tissue. So even if there has to be a dental implant, you have done something very good for the prosthodontic rehabilitation. So last topic for today, and we have a couple of minutes left, is bone preservation using TAD-borne temporary pontics. So typical situation, you have a missing lateral incisor, and in the future a dental implant should be inserted. What can we do in the meantime? Okay, so mostly in our department we like to close the space. Yeah, this is, for instance, we talked about the mesial slider. I personally would recommend in many situations, in young patients especially, to close the space to the mesial. But we still have some patients where we are going for space opening. There are also some dentists that are pushing the patients to space opening, and I like to discuss with you now what can we do in the meantime. So there's a big gap between the end of orthodontic treatment, which is usually at the age of 13 or 14, and dental implants are not inserted before the patients are 18. So how can we bridge the gap in between end of orthodontic treatment and beginning or start of dental implant insertions time? Of course, many doctors are using Maryland bridges or bonded bridges. You can use removable dentures. They both have their pros and cons, and I like to speak about the third alternative. We call this children's implants. Okay, the question is, are TADs an alternative? And you can use these Pontics on a mesial slider. You can use them in the palate, but as a third alternative, can we also use them directly in the area where we have a missing tooth? And I'd like to discuss this with you in the next couple of minutes. So this is a paper published in 2014. So again, all these papers are available for free on our website. If you want to try this, I can strongly recommend to do this. But we have to consider some points that you are successful. Point number one, the mini implants must have a crucial size. Yeah. I know Björn Ludwig and some other guys, they used mini implants as temporary Pontics. They had failures. Why? From my point of view, they used too small mini implants. If you use a mini implant with 1.5 millimeter diameter and 7 millimeter length, it's too short. If you bite on this, you will lose it. So in our department, we are using 2 millimeters and as a diameter and 13, so very long, millimeters as length. And the second important point, the mini implants must be out of occlusion, totally out of dynamic and static occlusion. They're not as good as dental implants. So why can we use them, or what is the idea? First, of course, we want to offer to the patient an aesthetic solution, but the bigger reason, the more important reason, we want to preserve the bone. We want to avoid bone atrophy. Okay, and Birte Melsen has published this paper, published 4 years ago, and she used some beagle dogs and has extracted bicuspids in those beagle dogs. And you see, in those areas where she had a mini implant in place, the bone atrophy was less, interestingly. So what did we learn from those studies, from this study? In those areas where we have a mini implant, the bone is still used, it's still needed, it stays. So it's good for the bone in this area, and the risk of bone atrophy is much lower. So Birte Melsen has inserted them from buccally, and our idea was, why buccally? Let's insert them like a dental implant and additionally use it with a crown on top. Okay, so don't put them buccally, put them like a dental implant. but with a smaller diameter. Why? If you insert a dental implant, you have a lot of growth inhibition because the diameter is so big. If you have a small one, the growth inhibition is very small. Yeah. So take home message of this paper: the transcortical screw caused an increase in bone density. So not just avoided bone atrophy, but additionally increased the bone density. Yeah. So very interesting from my point of view. As soon as you insert a mini screw in an edentulous area, the bone density becomes higher, the atrophy becomes less. So this is a very important research fact. Yeah. So again, we did a pilot study with mini implants in the alveolar process. We wanted to know what is a suitable clinical protocol, how about long-term stability, and how about bone atrophy. So in our study, we had at the beginning 33 mini implants in 14 patients, and most of the patients, as mentioned before, were in the area of a missing lateral incisor, but we also had 10 mini implants in the area of the central incisor because of a trauma. Yeah. And the patients had a mean age of 13. So this is, of course, a typical age when orthodontic treatment is finished in children. And we observed those mini implants over a time of up to 10 years. Okay, so this is a procedure. We do a little bit pre-drilling, not because the bone is so dense. The reason for pre-drilling is the alveolar ridge is mostly very sharp. Okay, so and if you don't do any pre-drilling, you may slip at the bone. So I do mostly a little bit pre-drilling. Insert the mini implant. Again, the dimension is 2 by 13, so is it still a mini implant? I don't know. It's a big mini implant at least. And then we take an impression and use nowadays a resin abutment. Very important. We started with steel abutments, but the aesthetic situation is not so nice. So nowadays we are using a resin abutment because it doesn't look so gray anymore. We saw this clinically. Yeah. And we can design these crowns now on the plaster model. So not in the mouth, it doesn't look so good, but on a plaster model from a technician. So these are the technical steps for this children's implants. Yeah. So let's have a look at some cases. This is a typical case. 14 years, end of the orthodontic treatment, missing laterals, and these are 2 mini implants that are inserted. Again, size is 2 by 13, and this is now the situation with the crowns. Sorry, I'm here with the crowns on top of the mini implants. Yeah, patient is happy. Yeah, he has an aesthetic solution. He does not have bonded bridges that are failing every 2 months. He does not have a removable denture. So one goal, patients are happy in their puberty, yeah, because they have an aesthetic solution in place. And the second goal is to preserve the bone. So let's come to results. Success rate was 90%. 3 out of 33 mini implant failed. Yeah? So the success rate is higher in the palate because we have a higher load here. Patients are sometimes biting on this, yeah. But very important again, the crowns should not be in occlusion. Yeah, they should be out of static and dynamic occlusion. We have to take care of this. This is, for instance, 10-year follow-up. Yeah, you see very healthy hard and soft tissues. A patient, of course, should clean this area properly. Some long-term results 6 years later. And funny situation is I'm calling them and like to see those patients every year. Yeah, I do have now many patients where that are now in the correct age for a dental implant, but they say, no, I'm fine with this children's implant. Please leave it in place. Yeah. So this is a patient started with 14, now she's 20, and she said, no, I'm happy. I don't want new implants. Funny story. Yeah. Another patient, 5 years in control with her children's implants. Everything looks very healthy. Yeah. So this was the patient I have shown you before. The male patient at the age of 14, now he's 20. And this is, of course, what usually happens because of the alveolar growth. Yeah. The children's implants crowns are, of course, after a couple of years, a little bit shorter. This is normal, yeah, because they are not growing like usually the teeth are growing. Okay, but we know this before, and because of the diameter is not so big like a dental implant, the growth impairment is not as big as with dental implants. Yeah? So this is very important. So let's come to the discussion. We don't have so many cases, just 33 mini implants. Why? We are mostly closing the spaces in our university. So if we have a missing lateral incisor, we are mostly not opening the space. We are mostly closing the spaces. So this is the reason why we don't have so many cases. From the OPG, it's very difficult to evaluate the bone, but this is what usually happens, as you have seen in the patient before. The adjacent teeth are further erupting, and of course the mini implant is not erupting. So after a couple of years, the crown is a little bit too short, what is not a big issue. But we have normal development of the adjacent bone. And of course, it's a question of the diameter. If you're using a big diameter or you have a growth impairment, if you have a small diameter, you have the risk of failure or fracture. So we found out if you are using a diameter of 12 and a length of 13, we find a very good very good solution that you don't have a risk of failure on one hand, but on the other hand, the growth inhibition is negligible, so you don't see it. Okay. So my recommendation, if you have a missing tooth in a young patient, you can think about this children implant to avoid bone atrophy. And as mentioned before, very important, we must choose the proper size of the mini implant, so don't use a very tiny one. And we have to grind the crown out of the occlusal contacts. And this is true for static and for the dynamic occlusal contacts. So as you can see right here, check it and grind the crowns out of occlusion. Very important, okay? So the success rate is okay, 90%. And of course, you can also use it for put brackets on these temporary crowns, as you can see right here. And you can use those temporary crowns also for uprighting. So right here we have 2 mini implants in place and 2 crowns. Yeah. So these mini implants are serving 3 purposes. First, the pontics, so aesthetic solution. They are preserving bone, and third function is they help for uprighting of the central incisors. Okay, so you can use them as anchors as well, as you can see in this patient. So we can use pontics on a mesial slider in the palate and in the alveolar process. Yeah. This is, for instance, in the anterior palate. So now I'd like to come to the take-home messages of my webinar today. You saw in the past, if it comes to molar uprighting and molar intrusion, we needed many brackets on the teeth. And of course, this is not a nice aesthetic solution for our adult patients. Nowadays, we can use a mouth trap. It's much more aesthetic. You don't need brackets for anchors. We can use uprighting spring on a dental implant or on the mini implant in combination with a bracket abutment. And I think this helps a lot. And my recommendation again, go to your referring dentist and offer these kind of aesthetic pre-prosthodontic treatments. We talked about PDL distraction. If it comes to ankylosed teeth, it's the last chance for ankylosed teeth, and even if the ankylosed teeth have to be extracted in 10 years, in 15 years, we at least have generated bone and soft tissue. We talked about the children's implants. You may preserve local bone, and dimension is very important. We are using 2x13, and it helps if you want to open the space for future dental implants. Communication with parents is very important. Avoid the words implant or bone screw. So mini implants or TADs, that's what we think. We spoke about palatal implants, especially in the first 3 webinars. But if you speak about them with a bone screw, patients may be very afraid. So this is maybe what they think. So my recommendation, don't call it screw or implants, just call it anchorage pin or titanium pin. It makes it more easier for our patients and parents. So at the end, I like to show you the website from our university. And here you find many, many papers about different topics, from molar uprighting, intrusion, distalization, early class treatment, mesialization. So many are there for free download. And this is the website of Dr. Sana Lendengold. She is providing the benefit system in Russia. And if you have any questions about what material you need, you can ask Dr. Jana. She's a very nice person. And so please go to the website for further information in Russia. You can also visit us in Düsseldorf. We have guests from all over the world. There is a direct flight from Moscow to Düsseldorf. I took this one today with Aeroflot. And you're very welcome to visit our department. Once a year, we have a very nice meeting about palatal mini implants. We speak about expansion with mini implants, distalization, mesialization, etc. Next year, we have Marco Rosa. He's doing the pre-congress course, but we also have Kenji Ojima from Japan. Ravinanda is coming from Connecticut, so it will be an outstanding meeting at the beginning of June next year. So please visit us in Düsseldorf. In the last webinars, I talked also about the new digital techniques. If you don't feel so familiar with mini implants in the palate, you can use these insertion guides. We are nowadays metal printing the appliances, expanders, distalization appliances, mesialization appliances. So if you want to see these new techniques, I recommend to go to the website of tedman.de, and you can order their insertion guides and a mini implant born mechanics. Just send us the STL file of the maxilla. So that's it. Very easy, similar to ordering aligners. So at the end, if you want to contact me, this is my email address. You can also contact me on social media. Yes, this is the last webinar of the 4 webinars, and hope you enjoyed it a little bit. I like to show you many indications for palatal, especially palatal mini implants. Distalization is for sure. The mesialization are for sure the most used indications in our hand. Expansion class 3 treatment is another interesting topic, but today I like to show you about interdisciplinary cases, molar uprighting, molar intrusion, and special situations like ankylosed, management of ankylosed teeth, management of impacted teeth. So I like to wish you a very nice and pleasant evening, and hope to see you soon, maybe in Düsseldorf or maybe tomorrow at the aligner meeting in Moscow. And goodbye and see you soon.